So the webinar is now live, and let's see. Did that go up?
No,
What do you see on your screen? No?
I still see the 5 of us.
Oh, shoot.
Well, I see. Oh, no, now there's 10, 11, 12.
Well, not,
I see 14 participants.
yeah, participants are coming out. I just wanted to get this LASE up, and they can probably hear us. So
You
let
can,
me. I thought this was going to come right up.
you sharing screen?
Yeah, I'm on share. Well, let me.
About how things went, how the experience was. If you have any ideas for future sessions, we're looking forward to expanding our attendance as well as the speakers we can solicit because we no longer have a geographical limitation. So, Carol, what do you think? Without, should we delay any longer? We have about half of our registered attendants introduced, Dr. Nisha Parikh. I think you can see her video. She's a cardiovascular disease epidemiologist and clinical cardiologist at the associate professor level at in the Department of Medicine, Division of Cardiology at UC Berkeley, at UCSF. She did her undergrad and MPH at UC Berkeley before going to the Northeast to do all of her medical training. She was at New York Medical College, then Tufts New England and Boston for internship and residency, and then stayed in Boston for fellowship in cardiovascular epidemiology at the Framingham Heart Study and cardiology fellowship at Harvard, Beth Israel Deaconess. She is now back on the West Coast, and her core expertise is in preventative cardiology, pregnancy, and cardiovascular outcomes. As the COVID epidemic came up, she let me know that she really had delved into understanding a lot about it and became a regional expert and gave some talks to educate her colleagues. So we're excited to invite her to educate us on what she has learned and enlighten us in the midst of this pandemic. Welcome, Dr. Parikh.
Thanks so much for the warm introduction, and it's really been a pleasure to meet you and participate in this. I'm going to share my screen and hope for good karma with the videos playing and such. So hopefully that'll go okay. Okay, here we go. All right, so the three large objectives of what I wanted to talk about today are, number one, to review the cardiac manifestations and echo finding that you might encounter in acute COVID-19. Secondly, I want to review the COVID-19, some of the chronic cardiovascular considerations with some imaging correlations. I think we're really early in objective number two, but I'll give you some of my hypotheses and show you a couple of imaging findings from some folks that have recovered from the acute COVID-19, but might have some chronic cardiovascular effects. And then finally, we'll review some safety protocols for echocardiography and COVID-19. Hopefully the background noise is okay. My kids are running around, so hopefully they won't be too loud. Okay, so in thinking about this talk sort of longitudinally, I think is going to mirror the way that we think about COVID-19 disease. So first you start with an infection, and I'll go over why the cardiovascular system might be involved in the first place, and why, and at least point out the epidemiologic data that's shown us that cardiovascular risk factors put folks at an increased risk of getting COVID-19 and being hospitalized with it. Secondly, we'll look at acute illness in terms of data that shows us that there's myocardial injury, probably an endotheliitis and hypercoagulability playing into cardiovascular disease effects. There has been now this sort of term called long haulers, and that's really folks that, again, have the acute illness, no longer potentially test positive for COVID-19, but have symptoms such as the ones I listed on the slide, and are now coming to our practices with those. And then finally, I want to talk about pandemic meta effects. And I sort of made up that term, so forgive me, but that really includes the types of echo findings we might see because of delayed care, including late myocardial infarction presentations, as well as stress cardiomyopathy, which we're noticing more and more frequently during this pandemic. So why is the cardiovascular system so important with this disease, given that it's a viral disease, and how is it different than other viral respiratory illnesses? I think the most obvious first observation that many of us had is that the SARS-CoV-2 virus, which is this sort of round guy right here with the proteins on the surface, binds to the ACE2 receptor. So that's the angiotensin converting enzyme 2 receptor. And that is really the mechanism whereby it's brought into the cell, replicates, and causes infection. And if we recall the renin-angiotensin aldosterone system, ACE2 isn't really the receptor that we've targeted traditionally with ACE inhibitors and then angiotensin receptor blockers and such, but it's actually sort of a counterbalance to the traditional RAS system that we're more familiar with. And so this sort of, highlights a little bit of that biology. So ACE2 is really more of sort of a cardioprotective receptor, and its downstream effects are what I'd consider cardioprotective if you compare that to the traditional RAS and the ACE1 pathway. So that's just sort of something to keep in mind. And it's been hypothesized by experts that this can cause, in addition to acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. So sort of that loss of the cardioprotective effects of ACE2 might lead to those types of things. And it is true that ACE2 is present in the endothelium as well as on myocardial cells, in addition to in the lung. Interestingly and different from previous epidemics such as influenza, comorbidities that lead to an increased incidence of disease and also severity include diabetes and hypertension. That hasn't really been seen before in viral respiratory illnesses, believe it or not. And sometimes those are even considered to be protective or just not seen in folks that get them. So that was a new finding and sort of a new observation with this COVID-19 pandemic. And it's true that if this data out of China in over 1,000 patients showed us that if you had 2 or more comorbidities, you had a much worse prognosis in terms of admission to ICU, being put on mechanical ventilation, or even dying from the disease, compared to those with no comorbidities in the orange there. So how can an echo then be useful, since this is the LA Echo Society? I'll bring it back to that, but I will veer off course once in a while, forgive me. It's just the rest of my background, I can't help it. So in terms of some of the cardiovascular pathologies, we've noticed that COVID-19 can predispose to acute coronary syndrome, might be by way of just sort of generalized inflammation. And also we've noted that there's an increased thrombosis and hemostasis with COVID-19. So this could lead to new regional left ventricular or right ventricular wall motion abnormalities, new functional mitral regurgitation, also acute heart failure, either very new or acute on chronic. And that could lead to structural changes in the left ventricle, increased filling pressures, and our echo correlates of that, as well as dilation of the IVC, elevated systolic pressures by way of left-sided failure. Cardiac tamponade, another reported finding in COVID-19. I won't necessarily show you an example of that, but it's important to look for pericardial effusions and any signs of tamponade on echo. And then pulmonary embolus is another potential finding, and also acute cor pulmonale from the pulmonary disease of COVID-19. And this is just a sort of another way of depicting that. So COVID-19 can cause sort of on the left there, a systemic inflammatory response, or SIRS, as well as later in the disease, antibody-mediated cytokine storm. And this can lead to DIC to microvascular occlusion and even macrovascular occlusion in the form of pulmonary embolism. So on pathology, we've even seen that the microcirculation, for instance, in the heart is can be affected, as well as the things we could see with the naked eye. So a lot of this plays into the heart failure outcome. Of course, we talked about the right side as well, potentially being involved, and then we'll talk a little bit about sort of direct effects of SARS-CoV-2 on the myocardium, all leading to heart failure. You can find a lot of things on basic echo, but we found that speckle tracking and strain have been useful as well. What have folks found? Well, in this study of 100 consecutive patients with COVID-19 who had complete echoes within 24 hours of admission, this is a group out of New York, they found that 32% of patients had a normal echo. 39% or almost 40% had RV dilation or dysfunction. Only 3% had valvular disease. 10% had LV systolic dysfunction and 16% diastolic dysfunction. And this was sort of their all comers. And the group also showed us an example of an individual. So on the left-hand column is sort of their baseline echo, and then 2 days later after they'd been hospitalized with COVID-19. So as you can see on the top, you have the mitral inflow that shows sort of a more impaired relaxation 2 days later. In the middle segment, you have the E prime, which gets lower. Their E over E prime gets higher. Their filling pressures indeed are higher. And then at the bottom, you have the pulse wave Doppler through the LV OT, and you can see that the systolic function as sort of demarcated by the LV stroke distance is lower. So LV functions declined in this patient. So these are sort of the Doppler findings that one might see in COVID-19. So how does COVID-19 lead to heart failure in sort of, thinking about this? So one, the stress of ARDS and sort of the lung injury. Number two is the immune response causing myocarditis. And so it's sort of that cytokine storm or just the immune response to the virus, independent of the heart muscle. And then three, direct infection of cardiomyocytes. So number one, we know is definitely true. And we've now have data, sort of all these months into the pandemic, scientific data that probably number two and three both contribute. And I'll show you a little bit of data. So down here you have the virus, and here you have the ACE2 receptor on the cardiomyocytes. And it can be both the immune response as well as by the virus entering the myocardial cells by way of the ACE receptor. And this slide is from my colleague, Bruce Conklin at the Gladstone. This is another slide that I am borrowing from Bruce Conklin. And this is basically data from Cedars and UCLA that shows that the virus spike protein, when tagged on human iPS-derived cardiomyocytes, shows that the virus actually adheres to the spike protein. And so indeed, it's sort of evidence that the virus can get into the cell. And what does this cause? Well, this data basically tells us that cardiac markers are elevated in COVID-19, including cardiac troponin. Over here, those that died had higher sort of levels of cardiac troponin compared to those that didn't. Myoglobin as well, C-reactive protein here in the third box plot, and then interleukin 6. So some inflammatory markers and some sort of cardiac injury markers are going to be more elevated in patients that do worse with the disease. Here's a case. This is indeed our first case that you'd consider to be a cardiac case at UCSF. And I should also give the disclaimer that we haven't had such a big epidemic in San Francisco, thankfully. So our case experience at UCSF is a little bit smaller than some of potentially even your centers. So this was an elderly man with chronic AFib, heart failure with preserved ejection fraction, and recently medically treated mitral valve endocarditis. He had been in a skilled nursing facility, and he was admitted to our hospital with shortness of breath, cough, and chest pain. He was afebrile, his heart rate was 73, and his vital signs were notable for a relatively lower blood pressure, 105/72. And he was satting 92% on 6 liters nasal cannula, so somewhat hypoxic. He was somnolent, and he had an elevated JVP with bilateral crackles and pitting edema. His chest x-ray was wet, which you could see here on the bottom left-hand slide, and then his ECG was notable for just AFib with some non-specific STT changes. Initially, he was admitted to the cardiology service, and this was sort of early on in the epidemic in San Francisco, and later a COVID-19 came back and he was put in isolation. He was given IV diuretics, norepi was started for hypotension. Again, later his SARS-CoV-2 RNA was positive. His echo actually, which I don't have here, and I apologize for that, but essentially showed that his LVEF was preserved at 70%. He had a mild concentric LVH and no wall motion abnormalities. He had some posterior leaflet prolapse with mild to moderate MR, which might have been just a touch worse than before a trace effusion. Unfortunately, with this acute on chronic heart failure exacerbation, he became increasingly hypoxic and had respiratory decompensation and was made DNR DNI, and unfortunately passed due to the illness. I'm going to now show you another case, and this time of myocarditis. And this is a borrowed case from the literature. So this is a published case in the Lancet. This is a 69-year-old man who was admitted to a French ICU in the Côte d'Azur for COVID-19 ARDS, and you can see that on his chest CT in the center of the screen here. He was put on mechanical ventilation, and this was his ECG over here on the right-hand side, which shows prominent voltage and T-wave inversions across the precordial leads. Because of this troponin elevation and ECG, was taken to the cath lab, but he had normal coronaries. So the next thing that was done was an echocardiogram, and actually he had normal biventricular function, which you can see here on this subcostal view with no wall motion abnormalities. Because of the troponin elevation and sort of the ECG findings, a cardiac MRI was performed, and this showed subepicardial late gadolinium enhancement at the apex, and that's sort of these arrows over here on the very right-hand image on your screen, and in the inferolateral wall suggestive of myocarditis. He was treated with 9 days of hydrocortisone, spent 3 weeks in the hospital, and was thankfully discharged home. So that's sort of an example of cardiomyopathy with a normal structural sort of echocardiogram finding, but elevated cardiac markers and cardiac MR that sort of revealed the diagnosis ultimately. All right. And this is case number 2. And when Ruchira shared that she was a pediatrician, I wanted to put in a pediatric case. So this is COVID-19 myocarditis second case. So this is a 15-year-old boy admitted with chest pain and a mild fever and a CRP of 41, had a troponin peak of 13. His chest CT was actually within normal limits, but he was COVID-19. He was positive. This is his ECG here, which shows just a little bit of peak T waves, but otherwise no sort of acute changes. An echocardiogram was performed. And let's see if it will play. And this essentially shows sort of mild dilation of the left ventricle, mild hypokinesis of the left ventricle, relatively normal valve function. And this LVEF was calculated at about 50%, so sort of low normal. His RV function, as you could see on the TAPSE, which let me just go back and see if we can show that a little bit more convincingly, was normal. And his RV function indeed was normal. Okay, let's see. Okay. He also had a cardiac MRI, and this showed late gadolinium enhancement. And that essentially is in over here. So there was posterolateral inflammation on T2 weighted imaging, and that's on image A over here, as well as late gadolinium enhancement on both the T2, I'm sorry, the delayed enhancement here, as well as here in image C. You could see sort of the whitish looking myocardial area here in the posterolateral segment, and also some pericardial fluid. So sort of a myopericarditis, if you will, in this patient. He stayed in the hospital 1 week and thankfully was discharged home in stable condition. So this is sort of case number 2 now of myocarditis. These are just path slides, which I'm not going to belabor in this echo talk, but that show lymphocytic infiltration on the left-hand panel and interstitial macrophage infiltration of the myocardium on the right-hand side. So two means by which inflammation is created in the myocardium. So COVID myocarditis conclusions from these cases are that patients can have a normal or a low normal LVEF, or sometimes even a low EF, and I didn't show you sort of a more severe case. Pericardial effusions are common, so be certain to look for those. Even trace effusions can sometimes give you a clue into something's going on. The disease can be multi-system. The lung can be involved, for instance, or it can be isolated, as in the case of the boy, the 15-year-old boy. Some patients can have a relatively rapid recovery. And cardiac MRI can be complementary to transthoracic echo. And I wanted to sort of switch over to another ventricle, which is the right ventricle, and just sort of review some of the parameters that might be important to measure when you're doing an echo on a COVID-19 patient. So just to remember that that in the RV assessment, the dimensions of the RV are important to measure in several different views, including the peristernal long axis, short axis, apical four-chamber, and subcostal views. And I like the ASC RV assessment document, even though it's a bit old now. I think it's still pretty relevant in terms of measurements and just sort of overall information. The M mode can be important with the tricuspid annular plane systolic excursion, and with a measurement of that, you can get another sort of gut check about RV function, at least at the annulus. And pulse wave Doppler can also be important, measurement of RVS prime, RVOT VTI, and pulmonic valve VTI can be important. We don't routinely measure RV strain, but some centers do. And then also just to sort of look at septal flattening in both systole and diastole in the short axis peristernals of the left and right ventricle can be important when thinking about RV overload states caused by either pressure or volume overload. This is some data that shows us that RV function in COVID-19 is actually related to worse outcomes. And this is sort of intuitive, but here's some data to sort of prove that. And this slide was prepared by one of our cardiology fellows, Ben Kellerman, when helping to give our grand rounds on this. So when they looked at the tertiles of RV longitudinal strain in patients with COVID-19, they found that compared to those with a middle tertile of RV function, those with the lowest tertile had a worse survival. And then when they looked at all three groups, those with the highest, middle, and lowest, they sort of settled out where you'd expect them in terms of survival. So those with the worst strain had the worst, and intermediate had intermediate survival. So in terms of a case of COVID-19 ARDS, this was texted to me from a friend who is an ICU doctor in New York and was part of the sort of extreme surge that they had of this, and sort of a middle of the night, sort of phone a friend echo sent to me. So this was POCUS, sort of just done at the bedside. And I think that they, especially at that time, really reserved full echoes for sort of the sickest of the sick patients, just given their extreme overload on the hospital. And indeed, in this patient who was hypotensive and hypoxic, and really the question she was asking should I give fluids, ionotropes? What should I do? We sort of took a look at this, and this is sort of a small hyperdynamic left ventricle on this sort of on this echocardiogram view here. And then, you can't even sort of see the edges of the right ventricle. I think it's quite large. And so this, definitely wasn't left ventricular failure, which she had been wondering about in the context of how the patient was doing. Okay, here's another case. So this is COVID-19 patient, a 67-year-old woman admitted to our hospital with COVID-19 pneumonia, hypoxia, hypotension, and tachycardia on mechanical ventilation. This echocardiogram was done, and on the parasternal long axis view here on the left panel, you see she has a relatively normal function, potentially, slightly generous to normal RVOT. But when you look in sort of this middle echo, she does have what I would call mild flattening in diastole and potentially systole of her septum, and her RV does look a little bit larger here. Her pulmonary pressure was 51. She did have a CTPE done, and she had pulmonary embolus. And unfortunately, due to sort of the severe ARDS she had and the lung injury, in addition to the pulmonary embolus, she ended up expiring some months into her illness, actually. So COVID-19 and pulmonary embolus and venous thrombosis, and arterial, actually, we've been noticing that these are connected. So risk factors for this are the things that are often risk factors just generally for coagulation problems, acute illness, stasis, and other things that might predispose, including malignancy, heart failure, et cetera. The hemostatic abnormalities can include, again, microthrombi that we don't really see with the naked eye in the lung, as well as in the heart, intravascular coagulopathy, myocardial injury, and you can see elevated cardiac biomarkers as we discussed. D-dimers are often elevated, and platelets are sometimes actually lower. Clinical outcomes that we're concerned about are venous thromboembolism, I have slippery fingers, myocardial infarction, as well as disseminated intravascular coagulation, or DIC. So thrombosis guidelines, this is ever evolving, but as of this summary in JACC 2020 from experts around the world in thrombosis, the conclusions were really that COVID-19 may predispose to arterial and venous thrombosis. Initial series suggests that a common occurrence of venous thromboembolic disease in patients with severe hospitalized COVID-19. But the optimal preventive strategy warrants further investigation. Many centers are doing therapeutic anticoagulation for any patients on oxygen, for instance, in the hospital. Drug-drug interactions should be considered, and then available technology should be used to optimally care for patients who have thrombotic disease during the pandemic. I think an open question is whether outpatients with COVID-19, for instance, need to be anticoagulated, or patients that recover and are discharged home. So those studies are essentially underway to help guide that. So what are some of the chronic cardiovascular effects of COVID-19? So say you actually get better and from the acute illness, but now are coming back. Well, in these quote unquote long haulers, some of the symptoms include palpitations, tachycardia, dizziness, presyncope or syncope, dyspnea on exertion, or chest pain. These are some of the things I've seen in my clinic, at least, and read about. So this is an echo from a so-called long hauler. This is sort of a young gentleman recovered from COVID-19 and fairly athletic individual. Has sort of a relatively normalish looking ejection fraction. The global longitudinal strain, however, was relatively low at minus 16%, so sort of low, just kind of in the low range. And the right ventricle was just mildly dilated at 4.6 centimeters. So this is just an example of some subtle findings that we've seen on echo. Whether or not these are going to turn out to be a pattern or something we look for, I'm not certain about. But for me, oftentimes the ejection fraction's been either normal or low normal and not exactly a slam dunk for something going on now in the chronic state. But I think strain can be helpful. And then a little bit of a close RV assessment is also helpful. Okay, and here is another another young patient also complaining of symptoms who has now an EF of 50 to 55%. And again, a global longitudinal strain was measured at minus 16.6, so sort of on that lower end for strain. Now, sort of to convince you beyond these anecdotes that I'm showing you of some of our patients that COVID-19 disease can lead to myocardial injury, this study out of the Netherlands looked at 50 healthy volunteers compared with 50 risk factor matched control patients, 57, about half were male, and the mean age was 49 years. The median time interval between COVID-19 diagnosis and cardiac MR was 71 days. Many had recovered at home, while about a third required hospitalization. And at the time of the cardiac MRI, the high sensitivity troponin was detectable in 71 patients who recently recovered from COVID-19 and were significantly elevated in 5% of patients. So this study showed us that on biopsy, there was lymphocytic infiltration of a myocardial biopsy of one of the patients. And then this was sort of showing that myocardial inflammation and scar was present in a number of patients. Let me see, what did I, oh, I didn't show you the actual data, which is, here it is. So this was sort of the more take-home message, which is that cardiac MRI revealed cardiac involvement in 78% of patients and ongoing myocardial inflammation. So that T2 weighted inflammation in 60% of patients. So the other thing we're seeing is that pericarditis and myocarditis might be also frequent in athletes, collegiate athletes with COVID-19. So another sort of sobering finding. Okay, and this is sort of examples from similar type of data of a small group of collegiate athletes. So I showed you this already, the subclinical LV dysfunction slides. This is just a repeat, and I'll just move on from there. So in addition to kind of these chronic effects, which we're really still learning about, but clearly are present, there's also sort of these more meta issues that I think we have to be aware of, which is really that there's been a reduction in activations of ST elevation MIs in the US. And part of that might be due to the fact that there aren't as many while people are relatively sedentary. But on the other hand, the other explanation is people are kind of waiting at home, not wanting to come into the hospital. And I think we can all imagine why, especially before we as a country had adequate PPE and sort of knowledge of the disease. And this data shows the same. This is from, these are AMI rates at Kaiser Northern California, just showing that as COVID increased here in the blue, rates of acute MI in 2019 were here in this sort of light peach. And then in 2020, there were pretty much lower rates, decreased by 48% during COVID period, same time frame. In a recent case from UCSF, there's a 52-year-old male who came to our practice, our hospital, I should say, with no known medical history. Several days of shortness of breath, pleuritic chest pain, back pain, shoulder pain. He didn't seek care because he thought it could be COVID, but he was encouraged by his mother to seek care, so he called EMS. This was his ECG. So as you can see, he has ST elevation in the inferior leads and reciprocal ST depressions in 1 and AVL, as well as V2. So he was taken to the cath lab and found that his right coronary artery was occluded, and this was ballooned and stented with a good result. However, he had sort of a recurrence of chest pain. So an echo was done, and apologies for the sort of difficult quality here, but this is a peristernal long axis view. Can't see too much. So we, when we put some color, I just wanted to show this because you see a little flash here in the RVOT of sort of what you'd consider potentially turbulent blood flow. And what should that be doing there in the RV? So that might be the first thing that draws your eye in this echo to something going on in this gentleman with sort of a late presentation of a STEMI. Okay. So unfortunately, in the subcostal view, in what I would consider sort of like an off-axis shot, this isn't sort of the perfect subcostal view in that you don't really see perfectly the tricuspid or mitral valve, and you're sort of seeing just a smidgen of the atria. So this is clearly not the view that we normally get in the subcostal. But unfortunately, you sort of see here that here's the intraventricular septum, and about, I'd say, right after the midsection as you're going into the distal, you see a discontinuity in the septum, and really a VSD. And so here you can see that the what looks, at least right now, potentially like bidirectional flow through a relatively large ventricular septal defect. So he was taken to the OR, and this was actually fixed. So he had a late mechanical complication of an AMI. And this is another case. So an elderly man with a history of chest pain 2 days later had a posterolateral STEMI, posterolateral Q waves. PCI of the left circumflex was prepared. He needed to have an impella for hypotension. And he continued to be relatively hypotensive, and a TEE was performed. And as you can see here, on this 5-chamber view, you have a ruptured papillary muscle, posterior papillary muscle here, and a resultant eccentric mitral regurgitation, which you could see here in the color Doppler view. So he had another complication of late presenting myocardial infarction, and that is a papillary muscle rupture. Okay. Case number 3. So this is a woman with, this is a little bit different of a flavor now. So this is a 6-year-old woman with chest pain and hypotension who came to our ER. And she had a what looked like ST elevations on her ECG. In echocardio, she was taken to the cath lab and found to have clean coronary arteries, and this echo was done. What you can see here is that she has sort of a large apical aneurysm, and she has a pretty prominent basal septum here. And in this elderly woman, could be considered a sigmoid septum. And so obviously in the next views, what you do see is that you have, on the basis of this sort of prominent septum and kind of apical ballooned heart here, you have some systolic anterior motion of the anterior leaf of the mitral valve, and you have turbulent blood flow in the LVOT. You have a sort of jet of mitral regurgitation as well. And this patient who had, again, sort of STEMI pattern clean coronaries. Let's see, actually, I thought I had one more slide. I had one more M mode I wanted to show you, but maybe it'll come after this conclusion. So if it does, I'll show it to you in a minute. But remember with, let me just look one slide down. Yeah, I switched the order of these. So the other thing you saw was the systolic anterior motion of the mitral valve leaflet, and you can see that here on M mode. So don't forget to do M mode in these cases. And she also actually had a gradient of about 60 millimeters of mercury. So this was Takotsubo in an elderly woman with a sigmoid septum that sort of classically, has been reported to also cause Whereas she might not have had much of an LVOT gradient in the non-Takotsubo state when her ventricle had normal function. Now with this sort of ballooning of the apex, it sort of, causes kind of a hyperdynamic motion of the base of the heart, and this gradient can be brought out in that setting. And so in this case, you want to remember a few things. So the Takotsubo with LVOT obstruction, social history is really important. It turned out upon closer questioning, she's had significant life stressors during the pandemic, with her husband recently suffering from being diagnosed with angina, coronary disease, and a bypass during COVID, as well as the loss of relatives and social isolation in the elderly population. So she really had a lot of reasons to have stress cardiomyopathy. In terms of management, just remember that you want to reach for vasoconstrictors as your preferred blood pressure raising medicines rather than ionotropes for hypotension. That can make the LVOT obstruction worse if you use them. You want to use AV nodal blockade, which is a little scary in patients like this who are hypotensive, but you can choose esmolol, just a touch of it, and really close monitoring, beta blockers, etc. Supportive care, because the prognosis for full recovery is actually pretty good. And that was a patient on service just a few weeks ago for me. Oh, I wanted to tell you one thing. So late MI, remember mechanical complications, image the entire mitral apparatus during these cases. Off-axis imaging may be needed for imaging acute VSDs because often they're not in the planes where we think they're going to be. I've been fooled by that at least a few times. And prominent high velocity flow in the right ventricle, even on images like parasternal long axis, can be your first indicator of a shunt where you might not have seen one before. All right, and then just turning quickly to this topic, which is safety in the echo lab in the COVID-19 pandemic. And these are really from the ASC that I've borrowed. So levels of precaution: standard care involves hand washing, hand sanitization, and use of gloves. The use of a surgical face mask in this setting may also be considered in standard care. Droplet precautions includes gowns, gloves, head cover, face mask, and eye shield. And airborne precautions, as I think most of us know now, special masks, including N95 or N99 respirator masks, or air purifying respirator, and shoe covers. So for standard, again, hand washing, gloves, surgical mask. Special droplet, sort of all of the above can be considered. And for airborne, you definitely want all of these except the surgical mask, not alone, but many of us wear the N95 and the surgical mask over just to kind of preserve the N95 for the airborne. And then in terms of some summaries of recommendations, think about deferring or rescheduling options for non-emergent cases. Assess patient COVID-19 status. In our hospital now, everybody is universally tested if they're in the hospital, and also before procedures, they are tested in sort of our outpatient drive-through setting. You want to provide appropriate levels of self-protection. TEEs are high risk. I think most of us know that by now, but that's really our highest risk procedure in the echo lab. There might be concerns about institutional PPE conservation, but I think most centers are pretty well equipped at this point now. You want to limit exposures during exams by problem-focused and limited exams, and be guided by prior studies. And then I'm going to go to this algorithm lastly, which is, ask yourself, is the echo indicated? And if it isn't, defer, reschedule as appropriate. But if it is indicated, you want to ask, what is the COVID-19 status? And if it's negative, you can use standard precautions, but you could consider droplet precautions. And if it's positive or suspected and it's a TTE or stress, then you want to ask yourself if, is it in the echo lab ward, cath EP lab, or ED, and then institute droplet precautions. We now actually routinely also wear, for any clinical encounter, wear the face masks, the goggles as well. And if it's in the ICU, operating room, or invasive or mechanical, non-invasive ventilation is being used, then airborne precautions are used at that point. And for TEE, it's always airborne precautions. And then there's also sort of special considerations that we should have about protection, including the use of protocols for POCUS and focused imaging, and then protection in terms of limiting staff participation and sort of like the observers, et cetera. And then things of that nature. So in conclusion, I just wanted to sort of now come to the end of my talk and just conclude some of the things that we have discussed. So thinking about kind of COVID-19 in this longitudinal sense with respect to cardiovascular disease, we talked a bit about the pathophysiology, the ACE2 receptor and the cardiovascular risk factors and how all of this interplays to create a really unique disease actually for us in this field. We talked about the acute illness and what, how is the echo useful? The left ventricular cardiomyopathy can have either actually a normal LVEF or a reduced LVEF, and an effusion might be present. RV dysfunction is also important to look for because it signifies potentially ARDS or lung injury and pulmonary embolism. In terms of chronic illness, there's not a lot of data, but I think that looking for a borderline LVEF or late gadolinium enhancement on CMR, or even looking at strain might be helpful. And then in terms of the, what I call the meta effects, I could be using that term in a wrong way, sorry. I just thought of it, that should be what I name it. But anyhow, this includes really looking closely for mechanical MI complications, both on echo, and I'm telling my trainees, listen to the heart, don't cut corners. Like if there's a new murmur, in these patients, like we really need to hear it, because sometimes that's really the first way you diagnose something. And then don't forget Takotsubo cardiomyopathy. We're seeing more of it. People are under a lot of stress, and I think we can't underestimate that. And we should ask about that. And then we talked about protocols and safety. So safety first, to protect yourselves and to protect patients. And we'll all get through this. All right, so where did my cursor go? Here. So this is it. This is my last slide. I just want to acknowledge the director of our Echo Lab, Ted Abraham, one of my mentors who was his predecessor, Elise Foster, one of our professors emeriti, and then my colleague Christian Soni, who gave me some pointers for where to find mechanical complications recently, Bruce Conklin, Greg Judson and Ben Kellerman and I gave 2 sets of grand rounds at UCSF, and some of my slides I'm thankful to them for. And with that, I can take some questions.
Thank you very much, Dr. Puri. While I wait for some questions to come up, I've got some of my own. I will bring up our intro slide for those of us who weren't on in time. And I'll just remind you, pose questions, please, in the Q&A section. The chat is disabled. And there should have been a poll, or Carol may be sending out a poll shortly to solicit your preferences for future virtual meeting times without the commute. You may prefer earlier times. I think I see the poll right now. And complete the survey that will also be going out shortly, and email that to Carol with your identifying information so she can grant you ARDMS CME credit. And I believe those are all the announcements. And then let's see if I can pull back up my Zoom screen to see if there's any Q&A. There we go. Okay, well, I'll ask I think I have to give up my screen share to pull up my Q&A. So I'm going to stop the sharing here now. Okay, I can pull it up. There we go. Well, my question, Nisha, is about the patients in whom perhaps we should be considering cardiac MRI in. I think that's really interesting, and not certainly on the pediatric end. And my very non-expert hypothesis is the reason that children are so minimally affected and so specifically affected with this hyperimmune response is they tend to have hyperimmune responses to a lot of things. They've got a more immunologic response to really about everything due to their immature immune systems, but also that perhaps they're having this subclinical myocarditis. Nobody really knows. If we were looking, maybe we'd see it because they don't have the predisposition to ARDS and the overt heart failure because they're not susceptible to that because of their young, healthy hearts. So I'm sort of curious about that because it very clearly, the SCMR, Society for Cardiac Magnetic Resonance, came out with a statement that if there's not a clinical indication, do not order MRIs. After that publication about MRI in athletes that was done at a major university.
Yeah, I mean, obviously the athlete situation is a little different because there's so much on the line if they continue to play professional sports, and we're often worried about arrhythmia in athletes and things of that nature. But I'd say for the general population, pediatric or adult, I think if you have ECG changes, if you have chest pain that is a little bit different than what you'd expect with a pneumonia, that's sort of more classically heart related, or if you have elevated biomarkers, troponin in particular, then I think it's reasonable to start to take a look a little bit more closely. And if your echo is normal and you still want to get to the bottom of what's going on, I personally think it's reasonable to do a cardiac MRI at that point to see if there's inflammation. And sometimes, you know, if you detect any sort of like pericardial inflammation or pericardial effusion, you could treat them for pericarditis. I have had a few patients I've treated for pericarditis. Not all of them have been tested for COVID and don't want to be now, but you know, some of them could certainly be due to COVID-19. And I think there's just a lot of things we don't understand about the disease. And now that I'm starting to see some of these folks with like chronic cardiovascular symptoms, I'm more curious about if they actually had involvement of the heart. And so some of it is really to better understand the disease. But I agree with the Society of CMR. We shouldn't just indiscriminately do the cardiac MRIs on everyone.
Yeah, absolutely. Though I do think we're going to be missing this subclinical disease and maybe find out after the fact. And the pericarditis is an interesting one. I've seen an uptick in pericarditis, and okay, them for COVID-19 because they exhibit no other symptoms. But and I think your last statement was a nice transition to one of the questions I see in the Q&A. What is the care plan for long haulers with low normal EF for the future? What do you anticipate for that?
You know, right now, I think if there is a low normal EF and they have the heart rate and blood pressure room, I would put them on optimal sort of, you know, goal-directed cardiomyopathy therapy just to give them the best chance of recovery. I wouldn't feel shy about that if it's possible. I've also seen patients in my clinic that have what I'm starting to think is like a POTS-like illness. And I almost want to see, you know, I haven't looked in the literature to see if it's been written about, but almost classic POTS symptoms, sort of tachycardia that could be positional, certainly with, that could either be associated with hypertension or hypotension, and a kind of array of nonspecific other symptoms. So to me, that's what it reminds me of, but I'm not.
Vasodepressed, like a vasomotor reaction.
A little bit. I mean, I don't know if it is, but that's like the first thing that comes to mind. I tend to take care of I have some POTS, people with POTS in my pregnancy practice, and then some just sort of general POTS patients because I'm interested in women's health, and we tend to see a lot more POTS in women. So
have you seen
reminds me of that?
And it might not be sufficiently large population yet, but a change in pregnancy-related cardiomyopathy or?
Yeah, what a great question. I haven't personally seen that. I know that there are issues with like preterm delivery and other sort of adverse pregnancy outcomes, but I don't think we've seen a whole heck of a lot in our PACT program, our pregnancy cardiac treatment program. We haven't seen a lot of sort of like COVID-related cardiomyopathy, as far as I know.
Okay. And veering a little away from echo, I have a question about hydroxychloroquine.
Oh, okay.
You would be interested in fielding that.
Sure. The data I've seen hasn't shown much in the way of efficacy. And I think that because of the issues with QT prolongation, it's actually led to I think there might even be a higher rate of arrhythmia and sudden death with taking it, because at least early on, some folks high up were very interested in it. And so I think a lot more people took it than would have been indicated. And I think that's basically some of the experience. And then there was an early experience in some of the hot spots with giving it before we really knew what to give. And I think there wasn't as much attention paid to the QTC at that point. And there was certainly a lot more arrhythmia seen. So yeah, I think in a nutshell, there hasn't been really any studies that have shown that it really works. So.
And do you feel that or has it been that the right ventricular findings seem to be in association with like core pulmonale, essentially in the context of the AS, in the context of, or they ever an isolated, is it ever an isolated right ventricular sort of cardiomyopathy or stunning?
I think it's what you first mentioned. I think it's pretty much kind of a proxy for how severe the lung disease is.
Okay.
And then if they have like a, pulmonary embolus on top of that, it makes it worse. It's interesting. Teresa DeMarco, who runs our pulmonary hypertension practice and heart failure practice, she actually, from the beginning, and I think it's been consistent even now, that population of folks with pulmonary hypertension, they actually haven't been as affected by COVID-19. And there's some thought that maybe the vasodilators they're on for the disease are actually been protective. So it's really interesting. That particular population hasn't been that kind of hit hard by it. So.
And maybe last question I would ask is, I think certainly early on, now maybe a little less so in a COVID-19 suspected or positive patient, what would be an expeditious but adequately complete protocol to really capture all the elements? You talked a little bit about TAPSE and strain, and I think when people are really trying to be judicious, get in and out, get all the information, what do you think would be a reasonable, sufficiently complete protocol?
Yeah, that's a great question. I think that most of the echoes are basically going to be looking for biventricular dysfunction. So I think that sort of doing your basic views is probably sufficient. I would do, like, if you had just one measurement, I like the RV focused apical four chamber. That at least the ASC, document seems to think that is one of the more what is that called? Reproducible measurements. So that one is the one that I usually like to follow and think about. So greater than 4.2 would be considered enlarged. And I think pulmonary pressure is important to get, obviously. Strain, I know strain is probably not, for me, as important in the acute illness. I think it's probably more important for these long hauler questions. And I think maybe, I'm not a strain skeptic, but I think I'm like appropriately wondering beyond cardio-oncology sometimes, like, where is strain going to be helpful for us? But I think in this case, it might be, because it might show us something subclinical that the CMR would definitely show us is there, but maybe we don't want to do it. So I think that it might be helpful in the long hauler population, honestly.
Yeah, strain is certainly going to be a lot less cumbersome than getting them to the MR.
Yeah, for sure. Yeah.
And I'll just say that Sid made a comment that it's interesting that I guess at Cedars, he's had the experience of seeing 3 patients on dual and triple antipulmonary hypertensive therapy, and they survived and did well. And maybe it's the RV being better trained, or maybe, like you're suggesting, the agents themselves could be somewhat protected. A lot of questions.
Yeah, thanks, Sid, and nice to hear from you. Yeah.
And I think we're all learning, and there's going to be a lot of ongoing collaboration and learning from each other on the fly. But I think we are running up to the end of our time
Great.
slot. This was
Okay.
really excellent. Thank you so much for your
Yeah, thank
time
you.
and participation. And it was really great to make a new colleague and friend.
Absolutely. Thanks so much for having me, and have a good night, everyone.
You as well. Okay.
Okay, so I'm stopping the poll.